Thank you. And I want the translator too, but I have to speak in English. So I'm going to present the outcome of colorectal surgery in Japan. As you know, the result, the overall survival is very good in Japan for colorectal cancer. So I'm going to present the reason of that. And before that, let me introduce the correlation of me and Chile. First, Dr. Aishi, Dean now, published that the screening for colorectal cancer with immunochemical fecal occult blood test was effective in Ugai. That was published in very famous paper. And after that, Chilean big guy and Dr. Aishi and President Oyama had the contract about the early detection of colorectal cancer in Chile. Pancho here. And in 2009, Dr. Aishi and us visited Clínica Las Condes after the contract. And I'm sorry, it's written in Japanese, but you can see that all the doctors are very young because Dr. Aishi was young 7 years ago and he's got a little bit old. And I was a little bit old, younger now. And Dr. Nagahori, who was in the bath with you yesterday, here, and some basic researcher visited Chile to see what's going on about the basic research for colorectal cancer. It was very, very long trip because first I fly to Atlanta by 12 hours from here, and for the transit it took 8 hours, and then 9.5, almost 10 hours from Atlanta to Chile. It was a very long trip, but that was okay because I'm familiar with that now. And I didn't know that Santiago is a very, very good and modernized city. I didn't know that. And architecture is very good in Chile too. And Clínica Las Condes was at the north and east side of Santiago, and the building's very clear. I didn't know that either. At 2009, a randomized control trial was planned, like for 90,000 patients from 5 institutes will be randomized half and half, and half of them will be screened by annual FOBT, and the other one is just follow up by telephone, and something like that, colonoscopy or polypectomy or like that, followed polypectomy. But 2010, a large earthquake was occurred in Chile, just 1 year before our large earthquake. And they changed the plan. That is not the randomized trial, just perform FOBT for 30,000 patients, and if the FOBT positive, you perform the colonoscopy in Clínica Las Condes and other branch hospital like San Borja Arian, okay, that is a main place of work for Japanese staff. And I did some paperwork and also in OR, because to improve the survival, I have to see how is performed in OR operation. And I attended at the conference too. What was discussed? And I visited some Borja Ariaran at that time because there is some Japanese center there. And it was a little bit old-fashioned room there, but it's renewed now, maybe. I also visit Valdivia and Austria. Austral is the name of the beer? Austral beer? No, university. Austral University. And my good friend Rodolfo is there. And Valdivia is south side of Chile, around 600 kilometers or like that, and very beautiful city. It's a view from my hotel, Boulevard Suite. A very good view, and it's a very good view too. And I enjoyed ski just once, but ski at the Valle Nevado, very nice. Maybe the world finest ski place there. And about the colon cancer, the incidence of colorectal cancer is increasing in Japan. And compared to Western country, about the male, it's almost the top of the world, and about the female in the group of top. So the incidence of colorectal cancer is increasing in Japan. And 5-year survival is very good in Japan too. The OS compared to US, very good for colon cancer and rectal cancer. Some researchers said that Japanese itself live longer. That makes the longer survival of, the OS in colorectal cancer. But in clinical trial, disease-free survival is also good in Japan. That means not the reason of prolonged OS in colorectal cancer is not caused by a Japanese longer life, but in this result, the treatment of Japan for colorectal cancer is nice from some reasons. So the improvement of survival of colorectal cancer in Japan is like that from old age, and not recently, but 1990s, it's increasing. Maybe it's due to we have JSCCR, Japanese Society of Cancer of Colon and Rectum, and we have original guideline other than NCCN, other than ESMO guideline. And maybe the surgery is good in Japan, white lymph node dissection. And the other one is careful pathological investigation. About the JSCCR, the recent president, Dr. Sugihara, is a former professor of this university who visited Chile. And a member of JSCCR are mainly a surgeon, but include internal medicine and pathologists, so very widely. And the main job of JSCCR is the publishment of General Rule Book, a Japanese original one. It was first it was published 2005, and now we have the 5th edition this year. And they publish a guideline for doctors and for patients too, separatedly. So patient can buy this one and read, and doctors have to buy the both of them. One reason of a good survival of colorectal cancer in Japan is maybe due to the wide lymph node dissection. I heard that Pancho, Francisco Lopez, do that D2 or D3 dissection, but it's maybe not common in Western country. D1 is the dissection for just pericolic nodes, but D2 and D3 is the dissection of lymph node to the root of the artery. The lymph stream is like that from cancer, so we do the D3 dissection very, very usually do the D3 dissection because we have the data that D3 lymph node dissection is superior to D2 dissection. So recently, Associate Professor Megumi Ishiguro in my department published that the Japanese guideline may improve the survival of colorectal cancer using those figures. After the publishment of a guideline, the D3 dissection improved. Can be performed everywhere. And about adjuvant chemo, after the guideline is increasing and increasing all over the Japan, surgeon can recognize that adjuvant therapy is necessary for stage 2 and stage 3 cancer. And these figures shows that the bottom-up manner of the treatment of colorectal cancer. That means for smaller institute and larger compared to larger institute, the improvement of treatment of colorectal cancer is very high in smaller hospital. That makes the bottom up of the treatment of colorectal cancer in Japan. The second one is surgery, D3 dissection. UK or Western countries manner is like that to resect very long bowel, but in Japanese style, do the D2 or D3 dissection usually. I heard that in German style, both long resection of bowel and dissect very large area of lymph node. So it's a typical Western style resection, and it's a typical Japanese style resection, D2 and D3, and guideline recommend that D2 or D3 dissection for all the stage 2 and stage 3 cancer. So in Japan, D2 or D3 dissection is getting common. The D3 right side colon cancer is like that, SMV and SMA, superior mesenteric artery. So all the lymph node removed. For left side, we can see the origin of inferior mesenteric artery. That means the wide dissection of lymph node performed. For rectal cancer too. So it was uncommon. D2 or D3 dissection was uncommon in Western country, but 4 years ago it was published in JCO. So it's getting common in Europe, but not in US maybe. This is side wall of rectum. The surgery for side wall, very big lymph node dissection. That may cause some side effect of sexual function or something like that, but for cancer treatment, sometimes it is necessary. The wide dissection of side wall is necessary. The last one is pathology. In UK and many countries, the pathological examination is like that. After the removal of a cancer, pathologists come and soak to formalin, and pick up lymph node after the fixation. But in Japanese style, resident have to do the lymph node pickup before the fixation. That makes a lot of lymph node will be investigated by pathologists. So Japanese guideline and other guideline recommend, I mean the NCCN guideline and ESMO guideline recommend 12 or more lymph nodes have to be investigated. But in the US, the median number of lymph nodes investigated is 9. But in Japan, 17. So that differences of the method of investigation of lymph node may cause a stage migration. Japanese method can detect very small metastasis that makes the stage 2, the number of the patient who diagnosed stage 2 is smaller, but very pure stage 2 without lymph node metastasis. And stage 3 include very small metastasis. I mean the metastasized lymph node is sometimes very small and just microscopically metastasis. That makes the survival of stage 3 greater. So maybe in Japanese method, both stage 2 and stage 3, the survival is better. That is secondary, surgery and pathological investigation. And the other one is follow-up system. A Japanese follow-up system is very, often. Before 2000, ESMO and ASCO guideline recommend almost no follow-up. If the patient have some symptom, let's do some CAT scan or something like that. But in Japanese guideline, we have to follow up the patient every 3 or 6 months by CAT scan without symptom, even if the patient doesn't have the symptom. So according to JSCCR guideline, ESMO and ASCO guideline was changed. So maybe they know that the importance of the follow-up for a symptomatic patient is effective to detect the early metastasis. And this is an important thing too. We have the general insurance system that covers 70 to 90 of medical payment. And we also have like a Medicare system for a poor patient and reimbursement system about beyond $1,000, the money will reimburse to the patient. At that circumstances, we can perform all the chemotherapeutic agent to the patient. That may cause the longer survival for recurrent patient. They are very, I can say it's effective, but toxic for adverse effect and toxic for in word of money, very toxic for patient. But in Japan, almost all the drugs covered by national insurance, so we can administer almost all the patient for very expensive drugs like that. And this is my last slide. The cause, the cause of the Japanese good survival for colorectal cancer is by good surgery and good pathological examination and good follow-up system, frequent follow-up system, and they are by a general medical insurance, good insurance in Japan for all the people. Thank you.
Thank you, Professor Uetake, for your presentation. And now, does anyone have a question to this presentation? Yeah, Professor Wright, please.
Yes. Thank you, Dr. Dagas. Beautiful presentation.
Thank you.
It's great to learn the number of different actions that were probably required to have a successful results
Right.
that you showed in Japan. Of the patients that you do follow up that do not have symptoms, but you're doing follow-up CT scans, what percentage do you find, it probably varies, I assume it has many different factors that influence, but in general, what is the percentage of recurrence that you find just through this CT scans done in individuals that do not have symptoms?
Yes, for stage 2 patient, 15%.
1-5.
1-5, yes. And for stage 3, around 25% after adjuvant chemotherapy.
And what do you do in those cases with these recurrences? You go to surgery again or chemotherapy or?
Yes, for liver only or lung only metastasis, we do surgery first, if resectable. And other organ metastasis like peritoneal metastasis, we perform Folfox and Avastin or Folfox and Uetake, something like that. If the patient, if I think the patient is necessary for very intensive chemotherapy, I select a Folfox and anti-EGFR like panitumumab or cetuximab or like that. If I can start with a milder chemotherapy, we start with FU and capecitabine and Avastin or Kpox and Avastin.
Any other questions? Now we have Chilean colorectal surgeons here. They have worked with us in the colorectal surgery team, participating surgery or endoscopy and the other medical activities with us. So, Dr. Sarate or Dr. Garcia, if you have any question.
Dr. Uetake, thank you very much indeed for your excellent lecture. My question is about the stage 2 colon cancer. What is your actual recommendation regarding the chemotherapy in stage 2? And the second one is for high volume centers in Chile, do you recommend some marker that we take in all patients like MSA or KRAS or only in selected patients?
For the first question, Professor Sugihara conducted a large trial for stage 2 adjuvant chemotherapy. And for ITT population, there was no significant differences by UFT only. But for selected patient, like T3 and venous invasion negative, UFT was have a good effect for preventing. So maybe we have to find the selected patient and selected drug. Like for stage 2C by TNM, maybe they need Folfox or some adjuvant. So we have to find the high-risk patient in stage 2. And the second question is about the anti-EGFR therapy, biomarker.
Exactly. Regarding if do you recommend if we take some biomarker in all the patients like MSI, for example?
Oh, yeah.
But, or only in selected patients? Because in Chile, as you know, in Chile we are underdeveloped country, so our income is not so high, so it's very expensive to take in all patients. What is your recommendation?
Yeah, for MSI, it is reported that the MSI patient have good survival, but worse survival by FULB adjuvant therapy. So if you want to perform the adjuvant therapy by FUs like capecitabine, you have to measure MSI. And for RAS or KRAS or BRAF, you have to perform it for the recurrent patient only.
Thank you very much, Professor.
Any question? Yeah, Dr. Garcia, please.
Thank you for your presentation. My question is very simple. How many years take to perform a colorectal surgery in Japan?
You mean the duration of the follow-up? 5 years. And now the survival is very good for stage 2 and stage 3. We follow up 10 years after the surgery for clinical trials. Just for 5-year follow-up, that cannot detect the difference of administration of adjuvant therapy or something like that. So we follow up 10 years in clinical trial. But in daily practice, we follow 5.
Is there any question? So thank you, Professor Uetake, for your presentation. Now I'd like to introduce our today's final speaker, Professor Araki, a gastroenterologist from our university. He's also a core member of the Joint Degree Program Committee, and also he's a specialist of the endoscopy, especially for the small intestinal endoscopy. So today he will be speaking of the situation of gastroenterology in Japan.